So coming back to your polytrauma, so we know now that we got number of scoring system. As far as orthopedics trainees are, you are required to know Gastello-Anderson classification for open injuries, few of its modification over the time, some by Gastello-Anderson themselves and some by other author. You are required to know, even if you don't know classification system, that you are always thinking of close injuries and their severity, especially compartment and impending compartment syndrome. You are required to know some scoring system for mangled extremity to know whether you need to salvage that limb or thinking of amputation of that limb. Obviously, not relying completely on that system. And then you need to know some scoring system or fundamentals of scoring system for polytrauma based on tissue damage, physiological response, and the host or the patient's comorbidity. And if you know this much, you're good to go with the scoring system. Coming back to the polytrauma, we have told you that a scoring system is good, but I'll tell you how difficult it is to adapt this in clinical practice. Polytrauma, you think that there are almost every month there'll be a few peer review paper about polytrauma, and if you search literature, you'll get hundreds of polytrauma patients. But till today, we haven't got a definition of polytrauma, or we don't have a consensus definition of a polytrauma. We know philosophically it is a clinical state following injury to the body leading to profound physiomorphological changing involving multiple systems. So we know that it involves multiple reasons of the trauma, and it causes significant physiological and metabolic changes. That's the philosophy of it. But how do we define objectively? We're not yet agreed. The number of ways people have said, could it be two major system plus one limb, one major, two major? All these have been associated. Should just injury severity score should define polytrauma? Some people say it's just 15, some 16, some 17, some 18. In fact, there has been an international consensus meeting in Berlin to define polytrauma, and they came with some ideas of defining what the AIS of two reasons should be called as polytrauma, with adding some physiological scoring to it. But even then, after that, a lot of research and paper has been published, and we don't agree to that definition. So even with the significant attempt to define polytrauma, objectively very difficult to define polytrauma. Number of papers have published definition of these monotrauma, multitrauma, or polytrauma, and sometimes they use interchangeably. We major trauma, polytrauma, major multiple fractures. All these can be used interchangeably. Although definition-wise, a multiple fracture is just extremity fracture with multiple, but sometimes we use that for polytrauma. Because some people only define polytrauma based on ISS more than 16, 17, or 18, and you could achieve that by just multiple fractures. So not well defined definition, but philosophically we know that polytrauma is a serious injury. So anything, the minimum anybody would think that injury to severity score of 15 or above. So some paper will say 18, some 16, some 17, but at least 15, and it is causing significant physiological damage or physiological alteration of the patients, and that is the injury which we define as polytrauma. So without going into the long discussion of controversies of defining it, let's have a philosophical definition that it is a serious injury involving multiple injuries, most likely multiple areas of injury, and causing significant physiological damage and leading to significant disability and death if you don't treat it properly. So let's have that as a physiological, as a philosophical definition of polytrauma. Having defined that, how do you manage a polytrauma patients? These are the broad guidelines or principles that life should be saved first, followed by limb, and then think of salvaging a function back to normal function of patient as far as possible. So these are aim or goals or an objective of treating polytrauma patients. How do we achieve this goal? First goal is to save life. So how do we save life? For that, first we need to know what causes these patients to die. And all of you are supposed to know this trimodal pattern of death in polytrauma patients. So a good percentage of them die almost immediately, and these are the serious injuries where possibly you can't do much unless there's somebody right at the scene and can manage some catastrophic injury. But most of the time, these are unsolvable immediate injuries. Then come which happen within hours, and they are about 10%, and they are responsible for a lot of injury when patients are brought into the hospital. And the most of the time we're talking about shock, hypoxia, and head injuries in this group. And this is the group where, as an orthopedic surgeon or as a team of a polytrauma management, you can make a significant difference, and you should know the principle of treating these patients. And then third mode is delayed or sepsis, and this you can directly affect. If you treat these, you can reduce the number here. So these are the two where you can make a significant difference. This, unfortunately, you can't make much difference. So how do we manage a polytrauma patient?